Hi and welcome. I'm Steve Martirano and this is the Behavioral Corner. You're invited to hang with us as we discuss the ways we live today, the choices we make, the things we do, and how they affect our health and well-being. So you're on the corner, the Behavioral Corner. Please hang around a while.
Let me welcome you guys to the Behavioral Corner and Happy New Year, if I haven't said that or not. There's never been a year more eagerly anticipated than 2021 for all the obvious reasons. And certainly we're, among that group. Bye-bye 2020. And who knows? Things got to get better, don't they? We're really grateful to have the time with our guests because it's a very, very busy time in the field of behavioral health, as you can imagine. Tom Longenecker has been a guest on the program at least once before. He's a great resource to talk about his field. He is now, it's interestingly enough, and he'll explain it to you, is now, I met him when he was primarily, when Retreat Behavioral Health, which is our underwriter, was primarily and exclusively a substance abuse and treatment facility. And now it's expanded to include the wide range of things we refer to as behavioral health. The side that handles the mental health piece of that is under the umbrella of Synergy Health Programs. And Tom is one of the, two track leaders that handle that, right, Tom? Is that how it works?
I'm the clinical specialist, and then we have 5 primary therapists who are working in 2 different tracks. And so I'm a resource for all of them.
Let's talk a little bit about this because some people are a little confused. When Retreat, who, as I said, is our partner, we're a renowned substance abuse treatment facility, and they expanded beyond that to include mental health issues. It was kind of a distinction, but not much of a change, because in the field of substance abuse, you always dealt with mental health issues, which are commonly referred to as co-occurring disorders. Now, of course, it's possible under a behavioral health model to separate it. You don't have to go get mental health issues singularly as a result of your substance abuse. So you're dealing with both kinds of patients, Tom, now?
So some of our patients purely have a mental health diagnosis with no substance abuse diagnosis. Mm-hmm. Others of our patients will have co-occurring, and we're able to try to address both of those at the same time.
Yeah.
Whereas in our other programs, some of our patients there have purely a substance abuse disorder diagnosis, and some will have substance abuse alongside with maybe a secondary mental health concern.
On the purely mental health diagnosis side, so that people understand, Retreat's behavioral health programs, you are not a psych hospital. So what does that mean, and who do you see?
Okay. So, the higher level of care would be an acute unit, which is going to be, noted by locked wards, oftentimes a short stay. We would be a step or so below that, where our patients, once they're through an initial 3-day isolation, which is COVID related, it's not related to mental health or otherwise, they're able to roam the campus. Now, they might have supervision, they might have a one-on-one aid, depending upon what their safety concerns are. But unlike a higher level of care, there are no locked wards. The doors to the rooms are not locked. They're able to, again, go to the CAF, walk up the hill, go to the clinical rooms.
Mm-hmm. Go to
the gym, play volleyball. So it's just like the rest of the campus, which is somewhat unique in that field. I think there's only 2. Don't quote me on this, but I think one of only 2 programs in the Commonwealth that have this kind of.
So everybody there under a mental health diagnosis is a voluntary patient. They're there because they're looking to get help. So in that regard, you see lots of your garden variety stuff. I mean, from anxiety and depression. What are some of the other things that you might deal with?
Certainly depression in its many forms is something we see very, very regularly, as well as anxiety in its different forms. We will also see some of what we in the past called access to dimensions, which would be borderline personality disorder, bipolar personality disorders. We also deal with some people who are coming in the schizoaffective dimensions of schizophrenia and its whole family of a cluster of the dimensions like around that with hallucination and delusion.
Right.
Suicidality is a very significant piece in terms of we are a next step for a good number of people who have been in dire straits not long before coming here. They might have had a brief stopover at an acute care location and then be coming to us for more for a longer period of time for care and to be doing some therapeutic work. So that would be a very significant.
All of that, as well as the substance abuse issues, have been, of course, monumentally impacted by this virus. Like every other aspect of our lives, it should come as no surprise that the number of overdoses have skyrocketed in the past year, and skyrocketed is the word here. As I say, it should not be surprising, but it is nonetheless shocking. The numbers I see from the latest CDC estimates between June of 2019 and May of 2020, 81,230 people have died from drug overdoses. That's a massacre, far more than die in automobile accidents. And just to give you a finer example of this, in the city of San Francisco, more people have died of drug overdoses than from COVID. Some of this is the result of just the sort of unfortunate path substance abusers are on, particularly when they're dealing with something like fentanyl. But in what other ways has this pandemic exacerbated the problem of substance abuse?
Well, I'm sure it's played out in several ways. I mean, I'm quite aware of people that we've worked with in the past who actually were able to pull together recovery and time and sobriety. And then they find themselves in, not so much in March, but April, May, June, very isolated. They might have been furloughed or lost their job. And one of the key things there is so many of the stories were that they were no longer in face-to-face relationships with people in the rooms and the 12-step programs or other places in the recovery community. And so you get a combination of isolation on its many different kind of levels, particularly isolation from the very resources that were part of what provided me strength to get through. Mm-hmm. And then you add to that loss of a job or a tremendous amount of time in my hands that I don't know what to do with. You know, some of our relationships are maintained because we have certain kinds of connection and certain kinds of distance. And, you know, I think many people can recognize when people have been in quarantine together, sometimes we know each other too well, you know, and but it raises those tensions and stressors there. Mm-hmm. And then you add to that again, some of the other resources that I've relied upon simply are not available to me in the same ways they were before. That's one piece of people who were actually making recovery work. They were doing what they needed to do, and suddenly we're in a very different world, and the things I relied upon to swim against the current are not available to me in the ways that I've become accustomed to them.
Are you seeing your patients face to face? Are you still doing that, or are you doing everything?
Yes.
You still are. Yeah.
Yeah. Well, here on the Hill, this is inpatient. So our staff, including myself, have been here for the most part since March through the time. So I've been here, aside from standard kind of days off, I've been here throughout that time. Our outpatient programs have been primarily telehealth and via Zoom and internet.
Tom is referring to the two facilities that anchor retreat here on the Northeast Pennsylvania area are in Ephrata and down the road in Akron. One is the outpatient, as Tom said, and the Hill is the residential community. But so let me ask you about the other side. I mean, I've spoken to Jack Sodak, who heads up Synergy for you guys and has been running the outpatient clinic. Have you had a lot of any experience at all with telemedicine, and is it helpful?
I have been doing some Zoom work. I would say it's certainly better than nothing. That's one way to look at it. I think it's a challenge. Personally, for me, I'm not very technologically adept, so I think it's a challenge in terms of how I am accustomed to working with groups and working with individuals. So there's just a personal, professional challenge for me in terms of having to retool. I think that actually, I would say that it's been surprisingly better than I thought it might have been. I just came out of having some decent group work across the last couple of weeks with groups that I was working with via Zoom. And I think they actually developed beyond my initial expectations and some of my own hesitancies.
Because you have great experience of being, as they used to say, in the rooms, and you don't even have to have that kind of a background. You understand that in any setting where you're face to face with one or more people, there's a whole lot of communication that goes on that's nonverbal. And you can only pick that up if you're in the room. People's postures, their hands, what they're doing with their body as they move, and that's all removed. How do you overcome that?
Well, and actually, you actually raised kind of an interesting point, because now when I am face-to-face with patients and people I'm working with, we're all masked. I'm missing a tremendous amount of just those subtle communications that are just hidden from me now. So when I'm actually on Zoom, I'm seeing more of a person's face. So
No man.
so it's an odd situation across the board, whether we're in face-to-face or whether we're on Zoom. I think probably one of the things that is beneficial about face-to-face is not just what happens face-to-face, but the things that happen afterwards, after the group convenes, or after it departs, rather. For people who go to the rooms, it's going out for coffee. It's all the other things that happen around that. Even on the Hill, where we're much more stylized and formalized, it's the conversations that occur after the group breaks, and the other kinds of ways that people who've been in it can go and they keep talking about, or they keep working through some of what happened there. Now that can continue here on the Hill, whereas I think that can be more limited when people are living independently in their houses and the only connection is virtual. The only connection is via Zoom.
Why is that carryover from out of the formal sessions into the more informal setting important? Why is that carryover important, do you think?
We are wired to be sociable, to be connected. And we can make a distinction between being sociable and connected. One of the key understandings of what's going on with addiction and compulsion is its disconnection. So part of the healing is deep connection. And so there's other very informal ways of simply being part of with depth in places where I know myself as somehow important to this thing that we're part of. And it's outside of the realm of condemnation, not necessarily outside the realm of judgment, but outside the realm of my worth. So I think there's a big piece of that. And again, neurologically, somebody who's in early recovery is going through a time period where their brain is starved for pleasure. Whatever substance they were using was providing to some degree something that the body interpreted as pleasurable. And we take that away from somebody during abstinence. And so we're going to go through a time period where the body's natural reserves of endorphin and serotonin are not up to production levels. They're still quite depleted. And so physical touch, there's skin-to-skin contact. Now that's what they teach new parents these days. Lots of skin-to-skin contact with your baby. Okay, that's bonds. And it provides tremendous amount of contact and tremendous amount of pleasure.
All of which has been cut off.
We talk about, sex makes people happy, but really the thing that actually really bumps up happiness is actual skin-to-skin contact. That doesn't necessarily need to be sexual to provide some of that.
No.
But that's a key piece. But again, that sense of being connectable, that is something that provides pleasure, so that it allows the brain to start to be less depleted and less really starved.
And in terms of therapy, it's always occurred to me that this carryover from the formal structure of, say, a group to the social aspects of after the group is beneficial, because it seems to me anyway that the person in treatment gets to appreciate as a process, not confined to, well, here's my therapist and let's sit down and do this thing here now and I'm done that. But when it's outside, when you have the cigarette or the cup of coffee or in the dorm at night, then it becomes not what you're doing, but who you are. You're working on your sobriety.
And again, it's into that kind of integration is just another kind of connection.
Yeah, connection, right.
It's kind of sinews together, right?
Yeah. And again, this virus has just disturbed the universe in so many ways. Do you worry that you get 81,000 people overdosing? There's a lot of reasons for that. One of which would occur to me is if people overdose, it's because they aren't getting to treatment fast enough or in time. Do you worry that people who ought to be seeking treatment, both for mental health issues and for substance abuse issues, are reluctant to do that, set against the backdrop of a virus?
I'm certain that that's partly the case. I mean, we start off with, and I'm not quite clear on this, the minute statistics on this, but relatively only about a quarter of the population that should or could be seeking substance abuse treatment is actually seeking substance abuse treatment. Yeah. For a variety of reasons. So we've already got really a minority of people seeking that who really should or could be. Add to that, the stigma of seeking treatment. Add to that concerns about being an institution where, rightly or wrongly, we suspect that we could be more susceptible to COVID. Add to that concerns about insurance. Who's going to cover those costs? Who's going to help me with those costs? Add to that also, I think the implications are trauma tends to be the gateway drug for much addiction. And look at some of the events that go on for this prolonged period that we've been going through as a country. And we have cultural trauma People lose jobs. People are unable to maintain their rent or their mortgage. Family relationships become much more tense. Economic concerns become heightened. And then you add to that the 81,000 deaths of people. Think about that in terms of who are the children who are left to be cared for by grandparents.
Yep.
Who are the spouses, significant others, the extension of family. And that adds to that whole level of how we experience something we get stuck in. It leaves its marks deep in us, and we remain stuck there. There's something that does not get resolved.
Yeah, 81,000 deaths creates not a ripple, but a tsunami of effects, emanating out from that. It's just incredible. Deadliest year in ongoing opioid and substance abuse epidemic, which got swept away, of course, in the wake of COVID. Tom Longenecker is with us. Tom is a clinical specialist with Synergy Health Programs. They are a part of Retreat Behavioral Health, and he's talking to us about what he does in the mental health field as well as the substance abuse. And we're going to pick up on something brand new to me, an article I read in the New York Times last week that Tom's going to try to enlighten us upon. We're on the corner, Behavioral Corner, hanging.
Studies show that 2020 has negatively affected the mental health of millions of Americans. That is why at Retreat, we work to provide comprehensive mental health programming through our Synergy Health programs. To learn more about Synergy and the comprehensive mental and behavioral health services we offer, call us today at 855-802-6600.
Tom, so I sent you an article in anticipation of asking you about this because I thought, well, how about this idea? The article begins with a fellow. It says Stephen Kelly had been addicted to crack cocaine for 32 years. When he tried a different kind of treatment last year, one so basic in concept that he was skeptical. What would happen is he would go to a clinic twice a week, provide a urine sample, and if he was clean, fear of drugs, he would then draw a slip of paper. It sounds like a game show, doesn't it? He would draw a slip of paper out of a fishbowl, and it would contain half messages, sort of encouragements. Good job, way to go. The other half were vouchers for, ready for this? Money. Cold, hard cash, moolah. Yeah, that's right. They were paying people not to abuse whatever substance they were abusing. The whole thing is controversial, to say the least. Very experimental, I think, and referred to as contingency management. Tom, I'm always suspicious of really jargony names for things. It makes me feel like they're, hiding something. What was your impression of this?
I think in some ways what they're working out of is a form of operant conditioning. So operant conditioning it's an attempt to reinforce or punish a behavior. Okay, so if I have to go to my probation officer and I provide a clean urine showing no sign of using, I don't really get a reward other than
I don't go back to jail.
I don't violate my probation. If I go and I provide a hot urine, or the probation officer might violate. I might have to have more legal issues. Okay.
Right.
Or for instance, our dog, I don't allow our dog to come on the carpet in our front room. And her options are to be praised for not going on the carpet. But the other part is she desires to be on the carpet because she's closer to the people she wants to be close to. And so her options are, am I going to get scolded and told to go off the carpet, or do I get praised? And so what operant conditioning is trying to relate a behavior to an outcome. And so at some level, what they're trying to do is relate ongoing clean time, ongoing abstinence gets potential reward. And I think in some things, it's you don't know what the reward will be. I think in some other programs, I'm under the impression that the reward gets higher each time. So maybe the first reward is $5, then 10, then 15. I'm not really sure how they always work that. But either way, the potential is I get rewarded for abstinence. And so relating the behavior of abstinence, or at least being able to show abstinence, with some kind of pleasurable reward.
If something like this is going to get a foothold in the treatment of substance abuse, the good old USA would be the place where, money doesn't talk, it swears. I mean, that's how we keep score in this culture. Who has the most money, who has the most toys. So I guess it would make sense here. I'm confused though, Tom, about this sort of, I understand it. Look, the techniques you just described are pretty much the way most conscientious parents raise their kids. It's as simple as that. You want to watch the movie, do your homework first. You want to go play, cut the lawn. I mean, stuff like that, and the denial of that stuff. We understand about that. But with regard to substance abuse, can the reward, no matter what it is, be so powerful that it cuts off the craving for a drug like heroin? I mean, can it work like that?
I don't know that I can answer that with authority.
What's your suspicion, though?
My suspicion is that if we look at this as one piece of an array of different interventions, particularly in early recovery, and remember that in early recovery, the brain is starved. And so some kind of reward is almost necessary. So for some people, that reward is I go to a meeting and I'm surrounded by love and affirmation, and we go out and smoke cigarettes and go to Friendlies and eat ice cream later on, or whatever they're doing.
Mm-hmm.
And that for some people is a strong, strong reward when I'm deeply craving some kind of pleasure. And it's even difficult to have some kind of pleasure. So I think we need to realize how that might function more acutely or more significantly, particularly for people in early recovery, and just recognizing just how starved the neurological basis is. Mm-hmm. So I think that, certainly it can work in some ways. In terms of actually challenging actual craving, I know in the article you provided me, they were highlighting this particularly for methamphetamine and cocaine dependency.
And cocaine, yeah.
As opposed to opiate or alcohol dependencies. Partly because we have medicines, we have pharmacological means to address some degree of craving with opiates and with alcohol. We have buprenorphine, we have Vivitrol, we have some of those means to address those. Whereas I'm not aware of an awful lot that we have that can really truly address really what is a parasympathetic craving for amphetamine of some form.
And so people understand this is not your garden variety treatment. And in fact, most insurance companies want more data, want more research before they're going to pick up the tab on this kind of contingency management. But interestingly enough, it's being done in our area at the VA hospital in Philadelphia. They are trying this out with a voucher program. Look, I'm like, I think most of you professionals in it, if it works, good. Let's give it a try. I mean, MAT now, which is medical treatment, medicines, as you just mentioned, was for the longest time thought to be something antithetical to treating this. Now it's not. That's changed. Who knows if this can work? But there are legal considerations to consider. I guess in some places you're not supposed to pay people to not use drugs, right? That's illegal.
Yeah. I'll play kind of the advocate for this for a second. But we also give bonuses for performance at work.
Sure.
People get paid to do surveys. In education, we have certain kind of rewards. I mean, that's actually, again, kind of go back to parenting. There's certain kind of rewards that we give. I know that people with mental retardation or on the Asperger spectrum, that there are certain kind of rewards that are built into the systems to work with behavior. Homelessness and substance abuse are two areas that I suspect that we're very reluctant to reward for doing the things that we think you should do anyway.
It's fascinating. I mean, we use words like reward, and then when you attach money to it, it's a very clear idea forms in your head. And what we're really not talking about how much money. You're giving people a sense of an affirmation. You've done something worthwhile. Here, this will remind you of that, and you'll keep doing it. I mean, I've always thought that one of the great reinforcers for people in sobriety is the accumulation of time. The longer you're sober, the more you want to make that a bigger number. How many days? That's why the days and years count. And statistically, the longer a period of time people have in abstinence tends to predict the longer time people have in abstinence. Yes, exactly. Right? It's the same thing. The longer time people have in treatment, exponentially per day, we see that it tends to be predictive of more time in abstinence. I knew you'd shed light on this for us. I was fascinated by that. We're going to find out more about that. There's some unbelievable stuff out there about technology, and I read about apps that now will do saliva tests on the phone somehow or another, and you can be rewarded right through your phone. So it's an amazing arena. Let me ask you, but I'm going to let you back to your very busy schedule, I'm sure. One day COVID will be gone, knock wood, and we will get back to whatever the normal is then now at that point. I'm guessing, though, that even if COVID were to be eradicated tomorrow, what you're about, the work you're doing, is not going to go diminish.
I'm positive of that. Yeah, luckily there's other jobs I can do. If we would ever fall into that world, luckily there's other things I can do.
I guess my question is, are we just on the cusp of a real sort of mental health crisis, or are we in a mental health crisis?
I think we've been in a mental health crisis and in a substance abuse crisis for quite a long time, which was exacerbated in the last half year or more. I'm curious in terms of seeing what the after effects are. Again, referring back to the 81,000 deaths, as you termed it, a massacre, in terms of how that plays out in the lives of people who are the witnesses and who stand by and have seen this, and these have been people who've been important in their lives. I'm expected to see, the tsunami of that effect. I suspect, because this is tragedy. This is tragic, and
grief has been delayed.
Grief has been delayed. Just even the kind of the communal means of funeral, which is a very simple way of marking that transition, that change. Well, this has been removed from us in terms of viscerally. So many funerals are now either not occurring, or they are occurring again virtually. There's a lot that can be done virtually, but we are still missing some of that basic connecting with one another.
Tom, thanks so much. For people who might hear this and are, cut off, isolated, struggling, what should they do? They can't sit there and expect this to go away. They have to be a little, do they call family? What do they do?
There are always interventions. If people can always call upon interventionists and others. If this is something that you're recognizing for yourself, so many people say, I waited too long. I thought the depression would go away. Or one of the problems with depression is I just don't have the energy to make the move. Or my anxiety gets in the way, or I'm just waiting for the right time to make the move. Things are never the right time. Okay, I want to deal with my drinking, or I want to deal with this problem I've got. I recognize it's a problem. I just need to wait, or I can do it without making the shifts to leave my home, leave my apartment, leave my family, take off however much time I'm needed to really become part of a bubble and address it. Those kind of reasons are constant, no matter if we're in the middle of a pandemic or not. But one of the things I hear over and over again is, I should have done this earlier.
Yeah.
Because people see the result. One of the great rewards I see over and over again for people who really invest themselves is that quickly they find this is like lifeblood. And so that's rewarding in itself. I suspect that there's a lot of things we could do that would draw upon contingent management in certain different ways of being more overt about providing certain kind of rewards. But one of those is simply the rewards of recovery, which is not without its trials, but not without its tribulations, not without its difficulties.
Yeah, there's a great expression that's applicable. Living well is the best revenge. It's also the best plan. Tom Longenecker, clinical specialist, Synergy Health Programs. Thanks so much for the work you do and for the time you give to us. We really appreciate it, Tom.
Thank you, Steve. Thank you for what you're doing.
Hey, guys, thank you for hanging on the corner with us. Don't forget, follow us on Facebook, Instagram, follow us in a cab, on a bike, like us. Never in my life have I had to ask people to like me because it never did any good, but like us, the whole thing. And look for us here on the Behavioral Corner. Take care, everybody.
That's it for now. And make us a habit, hanging out at the Behavioral Corner. And when we're not hanging, follow us on Facebook, Instagram, and Twitter on the Behavioral Corner.